Good day, ladies and gentlemen, and welcome to the SPSP Medicines WebEx series. My name is Joanne, and I'm your event manager. During the presentation, your lines will remain on listen only, and if you require assistance at any time, please key star and 0 on your telephone, and a coordinator will be happy to assist you. I'd like to advise all parties this conference is being recorded, and now I'd like to hand over to your host, David Maxwell. Please go ahead.
Thanks, Joanne, and good afternoon, everyone, and welcome to our August WebEx, a part of our monthly WebEx series focusing on our 3 priority areas for SPSP medicines. Thank you, too, for everyone that's joined when we've got such lovely weather outside. I think we're looking quite enviously out the window at the moment to some of the best weather we've seen. So it's great that you be able to join us today. And it's also fantastic that we can welcome 2 presenters today from Greater Glasgow and Clyde, who are going to be presenting on, I think, topics that are very close to their hearts, again, align quite well with our key priority areas for SPSP medicines. So for those that have joined the WebEx, we do also have the audio component, and we know at the moment anyone who's not a presenter is automatically on mute, and we'll open the lines throughout the WebEx to support some live question and answers with our presenters. So for those that have not been on our WebEx before, we really do encourage people to participate by using the chat box while you're on mute. And again, I can see already, and thank you, that people are introducing themselves via the chat box. And to get involved, please make sure you do select all participants from the drop-down menu, and that way everybody on the WebEx will be able to see your comments or questions or thoughts. So we are asking everyone at the moment to let us know where they are and what they do, and I can see there are a number of people doing that already. So welcome to colleagues from Forth Valley, Lothian and Grampian. It's great to have you on board. So the medicines team itself, again, it's really important to recognise that we've got a small but important team, I think, here at the National Office at Healthcare Improvement Scotland, with Arvind, our clinical lead, who's on the call with us today, Janet, Kirsty and myself. But it's really an absolute pleasure to be working with people across Scotland and support this WebEx series as we learn together throughout the year. We have, I guess, a number of key priority areas which we've really talked about quite a bit already, and we've expanded the WebEx series for 2017 to 18 to make sure that we broaden our focus not just on transitions, but looking at omissions or medication administration type errors, as well as high-risk medicines. So it's great today that we've got 2 presenters that are going to be sharing information on 2 of the 3 of these topics. So again, it's fantastic that we've got both Karen and Andrew here from GG&C, and I'll get them to introduce themselves in a moment. And part of the aim of our WebEx series really is to get people engaged and interactive, and so we've got a number of polling questions throughout today's WebEx, and I think we've already established this one as our key opener for all of our WebExes so far. So Joanne, can I get you to introduce and run the poll, please?
Certainly, thank you. Your first poll is: which of the following professions best describe you? A, medical, B, nursing, C, pharmacy, D, other, and please type in the chat box. Please visit your polling tab. This will be in the top right-hand side of your WebEx screen, and your poll is now open. The poll will be open for 10 seconds, so please visit the polling tab again in the top right-hand side of your WebEx screen.
Fantastic. So you can see there we've got a range of people represented on the call today, and we do encourage people to be quick. We have purposely only allowed 10 seconds for each of the polling questions for you to respond. We just want to make sure we've got enough time to get through both the presentations, but your opportunity also to get involved with the WebEx today. So it's great to have everybody here, and welcome. So without much further ado, I'm going to introduce and pass the ball to our first presenter, and that is Karen, and I'll just pass the ball to Karen just now. And Karen, if you can just verbally confirm that you've now got the ball, and we can move on.
Yep, that's great. Thanks, David. So I'm Karen Cormack. I'm the Head of Clinical Risk at Greater Glasgow and Clyde. And today I want to tell you about an initiative that we started quite a number of years ago, maybe about 6 years ago, for nursing administration of medicines, called Chance to Check. So first thing is to say is why me, why did I start this, and why was I interested in it? So I was interested in reducing risk to patients. Being a clinical risk manager, that's a big part of my job. I had some knowledge of some of the error types that were happening. I also have an interest and a knowledge in human factors, both the ergonomic nature and the psychology behind why things go wrong. And I also am an improvement advisor, and I had an interest in applying some of the methodology that I had learned as an improvement advisor to this project. I'm from a nursing background, so I used to be a nurse before I was in clinical risk, so I felt as if I had some on-the-ground experience of when nursing staff were administering medicines, what they were trying to do. And I had a desire to help reduce the burden of work but improve the quality of what was happening and reduce risk. So the topic was of interest to me because of the number of events. So medication incidents is one of the highest number of patient clinical incidents. The seriousness of some of the events that we had, so relating to either patient death or serious harm. I was also concerned about the inequity of disciplinary processes for nursing staff when a medication error happened. We're quite a big organisation, obviously, and have lots of different management structures across that, but I wasn't convinced that the same discipline was applied for a similar incident across the board. And I had some perceptions as to why things went wrong, but wanted to quantify that and find some solutions to it. That's the first polling question.
Thank you. So the polling question is, of these medication administration error categories, which would you be most surprised to find in your top 5 of error? A, medication omitted, B, additional dose, C, wrong drug formulation, D, wrong dose, E, wrong patient. Your poll is now open. You have 10 seconds to answer the question, and please visit the polling tab in the top right-hand side of your WebEx screen. Click on polling, and this will take you through to your polling tab.
Thanks for that. So we were interested to see what types of errors that went wrong, and one of the things that I was most surprised about was wrong patient. So I was interested in how that we could give a Cardex, a drug that was written up for one patient, to the wrong patient, and why that happened. So that was one of the things that spurred me on to look at this. So this is our results in Greater Glasgow and Clyde from 2015 of the number of these events that we had recorded. And you can see that the highest number is medication omitted, then additional dose, then wrong drug formulation, then wrong dose, and then wrong patient. Second polling question.
So our next polling question, of these medication administration error categories, which would you think would cause the greatest harm? A, medication omitted, B, additional dose, C, wrong drug stroke formulation, D, wrong dose, E, wrong patient. The polling tab is now open and will be open for 10 seconds. To visit the polling tab, please click into polling in the top right-hand side of your WebEx screen. Thank you.
Thanks for that. So I also had a look at of these, which did cause the greatest patient impact. And you'll see the ones that are starred here are the ones that caused the greatest patient impact. So although medication omitted was our highest number, they weren't the ones that were causing the most harm. So the ones that caused the most harm were additional dose, wrong dose, and wrong patient. And I looked at what we were going to do about all these different types of errors. So for medication omitted, we've just started some improvement work on omissions, which is quite extensive, looking at a number of different solutions and a number of different small improvement projects to try and reduce the amount of omitted drugs, because they come from a variety of error sources and not necessarily one source. For additional dose, this is really a documentation error in that they mainly come from the card decks not being signed that a drug has been given and therefore somebody else gives it again, or it's not documented that a drug is given in ED or theatres and then given again in the ward. But these three were the ones that we felt Chance to Check would help give a solution to. So the wrong drug, the wrong dose, and the wrong patient. And it's this aspect that Chance to Check is trying to improve.
Our next poll: what do you think are the causes of medication errors? A, lack of time, B, lack of experience, C, lack of knowledge of policy, and D, lack of concentration. The polling tab is now open. Please visit the polling tab in the top right-hand side of your WebEx screen.
Thanks for that. So to be able to find out what actually were the causes, then I actually did some focus groups. So the focus groups were across our organisation. So we had the number of hospitals. I think we did 5 different hospital sites. I specifically asked for on-the-ground nurses. I didn't want any lead nurses or anybody that was going to make the staff feel as if they couldn't say what they really thought. I didn't take any names of the nurses or where they worked, because I wanted them to feel free and able to talk about what they felt the real issues were. And I had some kind of carefully chosen questions in a particular order to try and get to the root cause of why these errors happen. And so some of the information that came from the focus groups were that they felt that there wasn't enough time to do the medication round. And they spoke about how their practice might be better at the start of the round than the end of the round, where they felt time was quite squashed. They said that they often had to fit the medication round in between giving out breakfasts and the ward round. They talked about having a particular time to do the medication round, even though you can't predict how many drugs you're going to be given out on that round. So I was interested by that and about their feedback on it. The other thing that they said was they felt that medication errors were common, and they could all recite a medication error that they'd actually done or heard about in their ward. They said that they felt it had become quite a kind of task-driven process, and it became quite rote and was done without having to put a whole lot of thought into it. They said that no interruptions doesn't work, so we've got a no interruptions policy, which I'm sure other boards have as well, and they felt that that didn't work and wasn't successful, and they were interrupted consistently. Probing a bit further about who interrupts them and why they're interrupted was quite interesting, and we've done a wee bit of other work on that, which I'm going to expand, but I'll come back to that in the end. they admitted that actually they don't always know what the drug is that they're giving. So especially if it's a patient who's a boarder and they're a surgical ward, but they've got a medical patient in with quite a lot of drug history, and there's an assumption made that it must be the right thing because they've come from a medical ward, and they may not always look it up if they don't know what it is because they're squashed for time. They also admitted that they don't always correlate what the drug is with the patient. So we had a number of incidents that were quite bizarre that you know, made me think they can't actually be doing this, to be thinking, why is this patient having this drug? So for example, we had a 28-year-old man who got a beta blocker for 3 days, and nobody queried why he was on a beta blocker because he wasn't in for anything that would require it. And it was discovered that when he came in, he came through accident emergency, his wife had emptied the drug cupboard, and in the drug cupboard was his black Labrador's beta blocker, which had been written up and then he'd been given for a number of days. And we also had a man who had his wife's hormone replacement tablet given, and with the non-diabetic patients given metformin. So obviously they start with a prescription error because this prescribing's wrong, but what I was pointing out to the nursing staff was that they haven't really thought about why that patient's getting that drug, and we would have expected them to do that. Another big one for me was the name band. So the wrong patients to get the drug, it made me question as to whether everybody checks the name band. So it's in the policy that they have to check the name band, and they know they have to check the name band, but they don't always do it. And if you ask any nurse, how would you give a medicine, they would mention that, but if you watch them do it, they don't always do it. And they admitted in the focus groups that they don't always check the name bands, and they have a list of reasons as to why they don't do it. So it's not like a lack of care. It's they have a reason why they don't do it, which I'll go into in the next slide. And there was an underlying worry that they would make a mistake one day, that they would do something wrong. So there was a sense of realising the importance of it, but really not changing their practice to reflect that. So looking at the name band, in terms of types of error, it would be classed as a violation in terms of that you know that's a policy and procedure you should do, but for some reason you're choosing not to do it. And so looking a bit deeper about that into why they choose not to do it, we also explored that in the focus groups. And one of the reasons was they said that they didn't have time to do it, which is a bit of an excuse because it doesn't really take that much time at all. Another one was, this was in relation to patients who was maybe getting some kind of medication in an IV bag during the night, or something's been changed over, and they wouldn't do it if they had to disturb the patient to do it. And they also felt that they don't need to check the name band if they remember who the patient is. So they might say, oh, I know him because he's been in for 3 weeks, or I did the drugs earlier, so I remember checking his name then. But they didn't really have it in their head that they were checking the name band with the Cardex, more that they were checking the Cardex with they know who that man is or that patient is, rather than thinking it was a documentation check. And that fascinated me in comparison to blood transfusion. So it's a very similar process in blood transfusion where you're checking the name band with a blood transfusion slip, yet they always do that. So I said to them, would you still check the name band for blood transfusion? And they said, oh yes, we have to do that because it's in the policy. But it's in the policy for medications as well. And they said, we don't need to do it because we know the patient. I said, but you know the patient for blood transfusion, but you feel you have to do it then. And there was a kind of light bulb moment where they realised that they had two different practices for really the same thing, but they had in their head sorted it as different reasons. And the real reason is that they give a lot more medications than blood transfusions. So they can make a kind of special process of a blood transfusion rather than doing it all the time for medications. And they also view the blood transfusion as checking 2 bits of documentation, whereas they don't view it the same when you're talking about a cardiac and a name band. And actually, the most common reason was this last one, is where they felt some kind of embarrassment to actually go and ask the patient their name or to look at the name band as if they would have forgotten who the patient is. And they felt that the patient would be upset because if you're checking my name band, you don't even remember me, you don't even know who I am. And they felt that that would be detrimental to the relationship with the patient. So this got down to this 4 key statements. So it's like a kind of checklist that each nurse would do as they're administering drugs. So the first one would be that when they're dispensing the drug into the cup, they would say to themselves, I know what this drug is. So if they don't know what it is at that stage, then they need to check and find out what it is. So it doesn't take any more time, but it does, because it's when they're doing an action anyway, but it means that they're thinking about what they're doing at the time and they're checking that they know what the drug is. The next thing they're thinking about is this drug and dose suitable for this patient, so they have to kind of do some correlation between why are they getting this, and that should also include allergies at this stage to check that the patient isn't allergic to this drug that they've been prescribed. The next check is to, on approach to the patient, ask the patient to verbally confirm their name, date of birth, CAI, whatever the process is in your hospital. And you do that by actually saying to the patient, hi Mr Brown, I just need to check your full name, so the patient understands, they know who they are, but they need to check all the details of it. And again, the last one is with the name band, checking the name band with the cardex. The most common wrong patient incident is when they have the wrong cardex in their hand, and that's why the error occurs, even though they know the patient, they've got the wrong cardex in their hand. So that's the 4 stages of chance to check that would teach the nursing staff to say to themselves every time they're doing a medication. It means we can have prompt cards for them to do it, but they learn it very, very quickly that they don't really need the prompt cards anymore. It means you've got a deliberate design every patient, every time. It's a standardised approach, and it allows staff to take the time to do the task right. So everybody in the meds round is getting the same quality of interaction. And acts a bit like a pause in the process, and that was coming from the SPSP stuff that I previously worked on in theatre with surgical pause.
Our next polling question, do you think chance to check could reduce error where you work? A, yes, B, maybe, C, no, or D, don't know. The polling tab will now open, and it is open for you to answer. Please click into the polling tab in the top right-hand side of your WebEx screen. The poll will be open for 15 seconds. Thank you.
Well, thanks for that. So there's a lot of kind of positive feedback, either yes or a maybe, so that's good. I believe that if you're doing the same thing every time, then you're more likely to achieve excellence. So it's one of these things where if they just do it every time, it keeps themselves right and it keeps the patient safer as well. I'm kind of running out of time, but other things that we considered while doing this was no interruptions and the reasons why that doesn't work. We're about to review our no interruptions policy, but I picked up quite a lot of interesting information about that during the focus groups that we'll include in our work there. We also picked up some issues to do with two-nurse check, and that often it's not actually a two-nurse check, it's two nurses doing one check between them because they both don't look at both elements of it, like both looking at the bottle, both looking at the Cardex, both looking at the name band. And the last thing we looked at is a post-round sweep, and that's in relation to drugs that are left on the patient's locker and not taken at the time of administration, because maybe some patients take some time to take their drugs, and a post-round sweep is before the medicine round's finished. They have to go back and make sure that all the drugs have been taken at the end of the round, gathering in the cups to make sure that it's all done. And that's me. I'm sorry I haven't been able to answer any questions that have appeared on the chat during the chat because it's too complicated to look at two things at the one time, but I'm happy to take any questions.
Thanks, and thanks, Karen. We've been monitoring the chat box as you've been going, and I absolutely agree. Sometimes it's hard to monitor both things while you present. But I guess some of the questions have been, I think Arvin's raised a particular question around blood transfusions being seen as potentially more of a high risk, making people more diligent at checking. Did you have any reflections on that as a particular example of a non-medicine but potentially a risky infusion example?
Well, we have had very few blood transfusion incidents compared to medication incidents. So medication incidents are much more common. I mean, you could say it's because you're given more medication, but the serious medication incidents that we've had where it's been the wrong patient, it is difficult to defend why they haven't checked the name band. Yeah. So, you know, if your lawyer asks you, so do you know the policy, and so you're meant to check the name band, so why didn't you check the name band? And you say, because I knew him well. Yes, but you had another man's Cardex, you didn't know him that well. It's difficult to defend. So it's just as risky. It can be just as risky. It's just that you get away with it most of the time. So you can give them the wrong medication and they're fine most of the time, but sometimes it has a devastating effect. And why take the risk?
No, and thank you. Just in terms of the interest of time, what I suggest we do is leave opening the lines for questions to both of you once Andrew's presented his work. So if that's okay with you, Karen, if you wouldn't mind passing the ball on to Andrew, and we'll ask Joanne at the end of Andrew's presentation to actually open all the lines for some more general discussion. But thank you very much for sharing the fantastic work that you've been doing in GGNC. So Andrew, once you've got the ball, feel free, it's all yours.
Okay, thanks very much, David. Good afternoon. So as you'll have seen from the plan, I'm going to speak about a project that I've been working on for a wee while, looking at patients self-verifying their own medicines reconciliation. So first of all, I just want to thank you for allowing me to present on such a big forum here. Just to introduce myself, my name is Andrew Carruthers, and I was a rotational pharmacist. I've just started a new job this week. And while I was a rotational pharmacist, I've also been doing a secondment 1 day a week with the clinical governance team within Glasgow and Clyde. And as part of that secondment, I was challenged with carrying out a quality improvement project, which obviously I done on the self-verification of MedRec. So just a poll to start off. It was just to see if anyone else across other hospitals or health boards, if patients are asked to verify their medicines or admission to their hospital.
Thank you. So are patients asked to verify the medicines reconciliation process on admission to your hospital? A, yes. B, no. C, not sure. D, don't work in acute care. Your poll is now open. You have 15 seconds to visit the polling tab. Please click on polling in the top right-hand side of your WebEx screen. Thank you.
Okay, so it looks like there's a bit of a mix between yes, no and not sure. So we can come back to that at the end of the presentation and just see if the model that has been proposed over where I'm working would be suitable for yourselves. So I wanted to focus on the medical assessment unit at the RAH, and this is an acute receiving unit, and it's mainly made up of referrals from GPs, but they also take some patients from A&E as well. Patients here may or may not be admitted to the unit, so traditionally this unit might not actually complete medicines reconciliation, as the patient might be there for less than 24 hours. However, the consultant who's in charge of the unit was keen for MedRec to be completed for every patient coming through the door. The main reasons for this was he felt that you couldn't treat a patient unless you knew what medicines they were on, and that these patients might end up being admitted, and it would mean that the MedRec was completed. As with everywhere, there is an ongoing challenge with completing MedRec, and when I was observing medical nursing staff on the unit, not just particularly that unit, I suppose across the hospital, I observed there was poor patient involvement compared to, say, pharmacy staff who I feel aim to speak to patients most of the time when they are verifying the MedRec. I decided to audit this within the unit, and I used data from MedRec pro forma and found that only 43% of patients within the unit were getting used as a source when the MedRec was completed. And from observing the patients, observing the medics, a lot of the doctors were just printing off ECS and using that as the sole source. So initially I wanted a project that would involve patients. I originally trialled this doing it straight from Cardex. I felt that would eliminate the chance, or perhaps not eliminate, but reduce the chance of transcription errors if patients were verifying straight from Cardex. And I'd done that through multiple PDSA cycles, and I was able to create a process that worked, but it was extremely time consuming. It took about 20 to 25 minutes per patient, so I didn't really feel it was a viable option. So I then worked developing a process using ECS, which I thought was probably a more simple option. So ultimately my goal was to develop a process that facilitates patients to self-verify their own medicines, but in a way that's viable and integrates with other admission processes and adds value to the patient journey. So before I got to MAU, I originally started this work in the acute medical unit, which is AMU, just to confuse everyone, which is a different unit within the hospital. When I started the work with the self-verifying medicines, it had very strict inclusion criteria, so patients had to be under 65 years old. Originally they had to be on less than 5 medicines, but I struggled for numbers, so I increased that to 10 medicines. The patients could have no capacity issues in delirium or be on any compliance aids. And from that, I was able, working with patients with PDSA cycles, I was able to develop a patient view, as I called it, ECS, and that was done by manipulating ECS on Microsoft Word to change the ECS to a format that patients found easy to view and manage. As I say, that was all done from patient feedback, so that involved removing columns that patients found confusing and changing the text size. At this point, I just want to verify what I mean by verification. So patients would, the idea is patients are given a list of their medicines, which is taken straight from ECS, and they're asked to either tick or cross their medicines as well as their allergies, and then add any additional information that they think is important that we get right while they're in hospital. This process was tested within AMU, and it was tested in 13 patients by different pharmacists. 11 patients were able to fully verify their medicines, and 2 weren't, but it's because they didn't have their reading glasses, so that was an important lesson that we learned. I then applied that same strict criteria to patients coming through MAU, the GP referral unit, and predicted that 65% of those patients admitted via MAU would be able to confirm their medicines based on the criteria that was set. I took this to the consultant in charge of the unit, and he requested that all patients were actually involved, except those from care or nursing homes, and that was just to be more inclusive, but also try and find out about what patients aren't able to verify. And this was taken to MAU on 3 different days, or across 3 different weeks as well. So, just some of the data from that. This is a bit of a non-conventional run chart I've got here, but I have plotted the patient numbers along the x-axis, and on the y-axis I have the percentage of medicines that the patients were able to verify, and I've done this for the 29 patients that were included across the 3 days. As you can see along the top at the 100%, Most patients were able to fully verify their ECS, and that was 27 out of 29 of the patients. And I just wanted to highlight a few key things that are on here. First thing is a couple of changes that we made throughout the process. So I had printed the ECS for the first patient in the trial, and after that clinical staff were trained to print the ECSs. It was great to involve the clinical staff in it. It obviously frees up time for the medical nursing staff, but it also works really well in NEU because the referred patients from the GP present to the clinical staff first before they go through to the ward, and they can then wait up to 5 to 10 minutes in a waiting area before they are then assessed by a nurse or a medic. Unfortunately though, clinical staff weren't able to modify ECS to the patient view that had been developed, and this is due to a clinical management decision, but they were still happy to copy the ECS onto Microsoft Word, which is a really simple change that you can do, and that makes the ECS font larger and it makes it easier to read for patients as well, and takes minimal time. So I initially thought being unable to modify the ECS to the view that was developed would affect the patient's ability to verify, but as you can see from the results, it seemed to have very little impact on the overall results there. We also introduced a cover note at patient 14, and that had written information. That was after feedback from a patient that I think there was a bit of ambiguity. They were relying on the CLARCS giving information to the patient what was expected from them to verify. So we decided to add just a wee cover note of, I think, 3 or 4 key bullet points for the patient just when they were verifying their own medicines, and that was attached to the front of their ECS. 2 patients weren't able to self-verify. One of those patients was able to still verify 26% of the medicines, and this was a patient who was on 22 medicines with a dessert box. I think that just highlights the importance of involving people in drug histories, even if they are on a compliance aid. That was initially one of the exclusion criteria, but that patient was still able to add value to their medicines. The other patient not able to verify any was an 80-year-old patient who was on 18 medicines on the ECS, and they found the process too difficult, so they didn't verify any of their medicines. Just to give you an idea, the average age of the patients for these 29 patients is 63. There was a range there of 18 to 85, so there was older than the 80-year-old who was able to do it. And the average number of medicines was 10, but again, there was a range there from 1 medicine to 29 medicines. The feedback from the medical nursing staff was very positive. They found it beneficial, they found it really time-saving. They commented that the ECS being printed alone was time-saving, but they also had the patient comments on that ECS, and they had the 2 sources there to complete the metric, and they found it easy to understand. Something that's really important to add on as well is the 28% of the patients were able to add value to their ECS. So these are things that we wouldn't have picked up on if we were using ECS only, and included some really important issues. So just in these 29 patients, there was a patient who was on a hospital medicine that wasn't on their ECS. A patient on methadone, again, wasn't on their ECS, and that patient was able to give the dose, but also the community pharmacy, without prompting, gave the community pharmacy that they normally receive the daily dispensed methadone. There was information about last doses, weekly medication, and insulin doses, as well as one patient who'd recently had medication adjusted by the GP that hadn't quite reached ECS. That was with diuretics. And we wouldn't have known that without speaking to the patient and giving them the time to write that down for us. So where the project was innovative, it gave all patients, obviously with the exception of care and nursing home residents, which was 1 patient throughout the trial, it gave them a chance when admitting to an acute ward to confirm their medicines. And this is acutely unwell patients, so I think in the past this has been trialled with elective patients, but I'm not sure if it's ever been done with acutely unwell patients who obviously presented to their GP and can't be managed in primary care. We were also able to involve clerical staff in MEDRIC, which added a whole other dimension to the team. This is obviously beneficial, that reduces the nursing and medical staff time, but as the clinical staff became more confident with the process, they became more enthusiastic and wanted more patients involved. So it was also, you would expect that would increase numbers. So patient involvement, the patients were involved at absolutely every stage of developing the process. As I say, it was PDSA cycles, and they let us know things they didn't like about the process, which included, well, the first one was the print was too small. That was the very first feedback I got. I tried to change that to landscape when printing ECS, and then found if I put it on Microsoft Word, the font was automatically bigger. So that was from patient feedback, as well as formulations. Why does it say non-applicable? Patients didn't understand what that meant or why it was even there. So in the patient view, that unfortunately, as I say, couldn't be used, but in the patient view, we just were able to remove that column entirely, and that saved that confusion. Feedback from patients as well was very positive, and you can see there's a couple of comments there where patients felt it was worthwhile, and the comments that they felt valued, that the information they were given was obviously important, and they got a say in their medicines. So some successes of the project, there was an increase in the number of patients used as a source metric, so the 43% initially when I audited it increased to 68% within the unit. As well, it's really important that we're involving the patients at this point, because in our age we're quite fortunate that a lot of patients bring in their own medicines, but these patients are normally coming from GPs, so you've already lost that one source. So by having the patient and DCS, you've got two really reliable sources there right at the front door. It was also observed that metric completion increased from 57 to 75, but I'm not taking any credit for that, because like anywhere, the metric is very variable in the unit, so there would need to be a lot more work to see if this is related to change or just part of the variability, but that would be very interesting to do. And there's obviously the added value that we got, which is perhaps more difficult to measure, but there was a lot of added value there in increasing patient-centred care. So I think I've mentioned the main challenge, or perhaps disappointment, was the clerical staff being unable to edit the ECS information to the patient view that was developed. However, it might have been that was too time-consuming anyway. I never got really a chance to try it. But in future, I'd definitely like to see if there could be work done in developing a patient view ECS that would maybe be populated straight from ECS rather than have to manipulate the information. Key points for sharing. I think the first one is don't underestimate patients' knowledge of their medicines. Even when they are unwell, they still have a lot of information to provide that is extremely important in their care. The reformatting of ECS isn't simple. I think I tried every way possible and then ended up even just with copying into Word and deleting columns. And I've wrote this down as a national project, but I've noted that each health board has a local say over how they wish their ECS to be presented, so I'm hoping that this is something we might be able to follow up locally within Glasgow and Clyde and continue the work around it. Areas we would like to learn from others, just whenever they open up the chat box, if anyone has any feedback, would see if anybody else has got experience of patients doing it. So I can see in the original poll, we've got a few patients who, a few participants who are doing that within their health board. If anyone has any inexpensive and simple ways to reformat ECS that maybe that I've overlooked, it would be good if you had any feedback for that, if anyone's got experience. And also, I think this is going to be the next poll as well, but just to see if anyone would think this would work in their area, or if has any ideas of how it could be rolled out to other areas. And there might be a particular focus there for A&E right at the front door for patients. So yeah, so it's the final polling question just there to find that out.
Thank you. And our polling question is, how easy do you think it would be to implement the model presented today in your clinical area? A, easy, we'll start tomorrow. B, keen to try, perhaps some small-scale testing. C, not sure yet, we'll need to discuss with others. D, already doing it. Or E, don't work in acute care. Please visit the polling tab on the top right-hand side of your WebEx screen. The polling question is now open and you have 15 seconds to answer the question. Thank you.
So yeah, that's interesting to see that there'd be some people keen to try, and also interesting to hear from the person who's already doing it. That'd be really interesting to see how their model looks.
Excellent. Thank you, Andrew, very much. Joanne, would you mind opening the lines, please, for everyone? I'm really keen that we do get an opportunity for people to ask questions or discuss any of the key points. You'll see that in the chat box through both Karen's presentation and Andrew's, there's been a number of questions and comments. And I think, Andrew, it's fair to say there are a few people on the call that are really impressed with the results that you've been able to demonstrate through that test of change through a hand of 29 patients. And I think the take-home message for me was around just over a quarter of the patients were what you identified as adding value to the process of being asked to verify their meds rec in quite a number of different ways. So, Joanne, would you mind opening the lines, please? And again, for people to ask any questions they might have. And particularly, I might go to Arvind first of all to see if you've got any particular questions or comments.
Thank you, ladies and gentlemen. Your lines are now open and interactive, so you're free to make any comments or ask a question. You're advised that to avoid background disturbance, please use your mute or secrecy button, and please also be advised not to place your handset on the floor. Thank you.
So, Carolyn, I can see you've asked a question, and I'll read that out from the chat box. You've asked, would it work if patients are asked to complete a med-rec confirmation form in the A&E waiting room? So, Karen, do you want to expand on that? Is that something?
Yeah, I suppose it was just when you said there about A&E, it maybe wouldn't work, but you were just saying, I just thought patients can sometimes be sat in A&E waiting rooms for some time. That they could potentially, but then it would involve, obviously, again, it would involve clinical or clerical staff, sorry, perhaps having to give somebody that and ask them to do it while they're waiting. But I don't know if that's me just being a bit random.
No, I think that's I definitely think it's a good point. They're obviously they can be sitting there for hours at a time.
Yeah, it might give them something to do.
Definitely, and that was. We had toyed with the idea of going to A&E with it, but we felt that that would be such a large scale already. And keeping it.
And there's a lot of patients that go into A&E that wouldn't need, are not going to be admitted or anything. But then I suppose there's a lot of patients who are in A&E who are not going to be admitted, but will still be given some form of medication. So if they have already confirmed their allergies and all that, it still could potentially be helpful. But
yeah, it'd be a lot easier, I suppose, wouldn't it, if you could do it there? Yeah, definitely.
Thanks for that. Karen, can I ask, there were a number of people that indicated in the final poll for your presentation that they were thinking that Chance to Check would make a positive impact on where they work. To put you on the spot, are there any resources or anything that we can direct people to help share this information further?
Yeah, I can send you some of the kind of resources that we have. If you've got a national site that you want to put them on, I can say we obviously have them on our own local staff net, but I can send them on to you, maybe David, if there's a place that you can put them for folk to share them from.
Certainly will, and one of the things I'm thinking already is we could potentially populate these alongside the recording of this WebEx today. So that's something we can definitely investigate. So thank you in advance for those materials. Can I ask, are there any other comments or questions from others on the call? And again, Arvind, do you have any particular questions or comments you'd like to make?
Yes, thank you, David. Thank you, Karen and Andrew. They were fantastic presentations. Karen, firstly to you, it was quite interesting to see that the biggest problem or the problem that had the biggest impact on patients was the additional drug administered. Did you have any ideas on what could be done to reduce that as well? I know your presentation was something else, but that would be quite fascinating.
Yeah, we've looked at what the reasons are. So there's been some work done in theatres because sometimes it was anaesthetists not recording that they'd given the first dose of something, or they'd given the Clexane and then it was given back when they were in the ward again. So there's been some work with anaesthetists to try and improve that. I'm not sure of what else is happening in the organisation. I haven't been involved in any particular improvement projects, but I know the other area that was highlighted is between the admission units and the wards about, again, documentation and making sure that things that are given in that area can be translated through to the other areas.
Another question of you, Karen, this is really important for us from questions that were asked at the MedRec Summit as well. People ask what the benefit of medicines reconciliation is, and it looks like you've got a lot of data on the actual harm related to errors in medicines reconciliation. We would love to actually share that and see how it compares with other safety errors.
Yeah, so what data is it you want me to share?
So for the cohort, for the group of patients who you looked at, it would be great to know what frequency of actual patient harm occurred from medication errors in those patients, and just as a sense of what medicine reconciliation could have prevented.
Okay.
Thank you.
Thank you very much. Can I ask, are there any other comments or questions to Karen or Andrew before we bring the WebEx to a close? I always take silence as a no, but I can see that, Gillian, you've just jumped in at the last minute, and you're absolutely right. That would have been exactly what I was going to ask as well. So Gillian's asking if we can potentially see the example of the ECS that you ended up giving to the patients to use, and can we actually add that as part of the resource following from today?
Yeah, of course, I can send you an anonymised version of a completed one, so you would see the patient information that they've added as well as the format that it was in. Yeah, absolutely.
That would be great, even if it's just the columns that were included or those that were excluded as well, just to give an idea of the information that you were providing. That would be fantastic. And I guess a final reflection from me, it's been one of the aims that has come out of the Medicines Reconciliation Summit earlier this year around how we genuinely involve patients in the Medicines Reconciliation kind of agenda. And this is just one fantastic example. And I know people have already indicated that they're doing it in their wards as well. So this is an ask from me. If you did answer that, and I think there were 4 people that answered the poll to say yes, in addition to Andrew, we would love to hear from you. I think it's a commitment for us that we really want to be able to share the ways that people are genuinely involving patients in this process, because the medicines and the patients are the one constant when you think about people moving through the health and care system. So again, thank you so much for sharing that work. And Karen, again, thank you very much for sharing your work today. So before we do close, I just want to remind people this is a monthly WebEx series, so we're not going away. Next month, we're going to be focusing on high-risk medicines as our theme, and we're going to be hearing from colleagues working in both pediatrics and also primary care dentistry. So quite a broad range in terms of the care settings, but I think some fundamental principles about how we manage high-risk medicines no matter where you work. We'll be moving on to omitted medicines when we come back together in October. And again, a couple of boards are going to be sharing their experience. And I think it builds on some of the aspects you've highlighted today, Karen, about how we can improve the rate of omitted medicines in care settings. And finally, but not complete, this is only just a forward look for the next 3 months. We're going to be hearing from our mental health colleagues who are currently testing a clozapine handy guide for users as a way of involving patients or service users to better manage their clozapine and the side effects. So we're really very much looking forward to hearing the results of those. So as I've mentioned before, the WebEx today is going to be recorded and it's going to be available on our website. Can I encourage you to share that with others that have not been able to make it today? And we'll also promise to make sure that we provide links to the resources, both from Karen's presentation from Chance to Check, and also an outline of the type of information that's been included in that patient ECS view. So that really does draw us to a close. Thank you all for joining us on what has been a really lovely day outside, so we appreciate your time with us. And we look forward to seeing you on the 21st of September. So thank you all very much.
Thank you. Ladies and gentlemen, that concludes your conference call for today. You may now disconnect. Thank you for joining and have a very good day. Thank you.